सर स्टार्ट करें?
Okay from my side, sir.
Yes sir, मैं स्टार्ट कर रहा हूँ सर.
Okay.
A very good evening to all the doctor. Thank you so much for joining us for today's webinar. Our endeavor is to spread awareness about rabies, which is fatal. This is an initiative from Kerala through its innovation to serve the society and humankind. The topic of today's webinar is dosage reduction strategy in rabies management, role of novel vaccine. Dear Dr. Rabies is the world's first 3-dose anti-rabies vaccine, and we would like to inform you that the Rabies complete 1 year of launch, more than 40K animal bite victims being vaccinated, 100% compliance, and no case of adverse reaction was registered. With this, it is honor you to the
Your voice is not audible, sir. Voice is not audible. चलिए हमारी गई उनकी पे मुझे कैसे पता हमारे एंड पे नहीं है.
स्लाइड.
हेलो.
हाँ सर, स्लाइड स्टार्ट कीजिएगा.
अच्छा, we going to hear you for 5 minutes.
Yes sir, yes sir.
Dear friends, good evening. We have a small presentation about the rabies, a deadly disease which is not curable. And Kerala has developed a novel vaccine which is only first in the world, which has a great compliance. It's 3 doses only, 0, 3, and 7, which is actually innovation from the Kerala. So this is we're going to talk about the rabies. Something about the rabies you must know about it. Globally, there are about 60,000 human deaths annually, highest in India. India has about 20,000 human deaths a year from rabies. That accounts to at least 60% of the rabies death in Asia and 35% globally. Out of 191% deaths in India occurred in rural areas. Now, what is the current management in the rabies? What norms we are supposed to follow? The only first is the local wound treatment. That is the first aid. You have to wash the wounds with soap and water and disinfectant for at least 15 minutes. Then we have a active immunization, the vaccines. Then we have a passive immunization, the human globulin, rabies human globulin, which is given, that is called a passive immunization. Regarding the vaccine, there are 5-dose vaccine. It is given in 5 doses. That is, the day start from 0, then 3rd day, 7th day, 14 and 28 days. The compliance only take 5 doses. Only then the vaccination is complete. Compliance is there. Only then the immunity is perfect. Otherwise, the immunity lacks and patient can suffer. What is the current challenge of post-exposure prophylaxis? What is not? First is the current challenge is the non-compliance. People do not comply with it. They forget the date. They do not take on the required date. They do not take the full 5 dosages. Current rabies vaccine are called all cell culture vaccines. Then we have inactivated vaccines which are there from the more than 50 years old technology. What is wrong with the old technology is inconsistency in potency, stability, availability, short supply, and adverse events. The most important is the issue is the compliance regarding the anti-rabies vaccine. The compliant means who received the full course of ARV, that is the scheduled dosages 0, 3, 7, 14, 28, according to the without any change in between. There are certain they are delayed compliance. Some people who took instead of 28 days, taken 60 days to have 5 shot, they're not taken on a due date. That is a delayed compliant. There are certain dropouts and non-compliant also. People they take one vaccine and they forget it and they do not take on the desired day, say third or seventh. And there are certain people who do not comply with the full 5 dose. That is, sometimes will take longer, they sometimes forget it, sometimes they're not according schedule. This is the major challenge is the compliance. Now, what is the problem with the compliance? With the non-compliance to 5 doses, this is a proven cause of death. We have so many studies where we have seen, we have a data. This is the 3 patients data. This is first in the 58 years persons they bitten by a street dog. He was given 3 doses purified chick embryo cell vaccine, that is Rabipur 0, 3, and 7. He was not given rabies immunoglobulin. Then this dog bite category was 3 at the right side of the nose, and 20 days followed by it, he had developed paresthesia of the face, and then there was a fever, restlessness, and then altered sensorium. And then dog bite category 3, not done due to he left Lama against medical advice. He developed dysphagia and restlessness, and he died after 3 days. The second, again, a street bitten by a street dog, had 3 doses, 0, 3, and 7. No rabies immunoglobulin was given. This is again a category 3 dog bite was there. It was bitten at the left mid calf. After 15 days, it developed dysphagia, restlessness for 3 days. And then their diagnosis was confirmed, considered as a rabies encephalitis, and confirmatory test was done, rising serum of cerebrospinal fluid and virus neutralizing antibody titer was compared, and this was not done in the second case because of the patient left against medical advice. MR findings were not done because he left without any knowledge, and supportive protocol was not followed, and a patient same day admission death followed after 2 days. Again, a third case, 3 doses vaccine, type unknown, bitten by a street dog. It was again category 3 bite on the right dorsum of the foot. After 17 days, developed dysphagia, restlessness for 3 days, and dyspnea. The CSF finding levels, total cell was 60, monocarb was 100%, protein 84%, sugar 58%, and negative staining. Diagnosis again considered was rabies encephalitis. Rabies RNA PCR positive from cerebrospinal fluid and serum, but virus neutralizing antibody titer was not there. Not done. MRI finding was not done due to early death. There is a modified male wonky protocol from the day 1 was followed but expired on the day 2nd of the admission. The reason of death may be due to the lack of administration of rabies immunoglobulin or not proper vaccination. Now, compliance to post-exposure prophylaxis among animals by patient. This is a hospital-based epidemiological study. This was done at Satyam Hospital, New Delhi. Number of involved was 360 animal by patient involved. As pre-designed, pre-tested structure questionnaire was administered by the interview technique. Only, you can see in this pretty chart, 53% were non-compliant to the full course of ARV. Only 48% compliant with the proper dose 0, 3, 7, 14, and 28. 16% did not join, 46% didn't comply, irregular dosages, not on the proper day, not taken a complete. We know that the compliance is a big issue. Now again, there was a brief research article, compliance to anti-rabies vaccination in post-exposure prophylaxis. This was done at Municipal Corporation Hospitals, Bangalore. Number of patients study was 315 animal bite patients. 1 dose of rabies vaccine administered intramuscularly on days 0, 3. One dose of rabies vaccine administered intramuscularly on days 0, 3, 7, 14, and 28 as we know is a post-exposure prophylaxis. Also measure a constraint for compliance to complete course. The compliance was about 60%. not more than 60%. You can see in the chart. We start from the day 0 up to 28. The compliance went on decreasing 100 to 88, then 85, on the 14th day to 70%, and 28 is only 60% have the compliance. Now, what are the reason for non-compliance? What are the reason we have to think of it? Why anti-rabies vaccine is the compliance is there? Because there are a lot of reasons. They interfere with the school timing. A lot of people are not able to go to the proper places to have vaccination, either hospital or the dispensaries or the doctor. Then distance, they are staying far away from the hospital, say the remote village distance, and cost in occurred. Some people can't afford it. Then again, forgotten dates, some people forget it. And some people are scared of losing their job, loss of wages is they are not able to go on the proper days, due dates like 0, 3, 7, 14, 28. The major constraint for not compliance was the loss of wages, that was about 47%. Now the evolution of rabies vaccine, how it developed. Say it started developing anti-rabies vaccine was started in 1885. It was developed from the nervous tissue, live attenuated vaccine from the spinal cord material. Then again in 1911, inactivated vaccine was developed from the brain cells. Minimal neural content liquid preparation was done. Then again in 1976, it developed from the cell culture, inactivated vaccine. The cell culture was more than 2.5 international unit per ml. This was the standard immunogenicity lyophilized vaccine. This was the 5 doses which was started in 1976, which was to be given as 0, 3, 7, 14, and 28 to complete the immunity. Now, what is the non-compliance led to evolution of treatment in this regime? Earlier, when we started this vaccine, there were 35 dosages, then 25 dosages, then 14 dosages, then again 5 dosages. Now we have a novel vaccine which has only 3 dosages and is a short duration 0, 3, and 7. This is the technique developed by the new vaccine which is launched by the Kedla company. Because this is the unmet need, certain unmet need which can fulfill because of the shorter duration and minimal material and easy for compliance. Now this is introduced, which is a novel vaccine with a simple shorter regimen developed by the Kedla. This is called novel 3-dose recombinant rabies G protein vaccine. This, if you see, this is the first protein subunit vaccine. This is prepared by the VLP platform technology, virus-like particle platform technology. First vaccine with 3 doses, intramuscular regimen, 0, 3, and 7. This leads to better compliance due to easy to flow regimen and less visit to the center where it is to be given, and is a convenient, ready to use. No reconstitution is needed. This is a novel about this 3-dose recombinant vaccine developed by the Kedla company, rabies G protein vaccine. Now, what is the good about the VLP technology? We must know about it. This is a native virus. You see on the diagram, you can see this is a G protein is difficult to stabilize. G protein isolation using VLP technology purified and stabilized by Kedla Pharmaceutical Company. This is the first in the world. Then virus-like particles are protein complexes exist as nanoparticles, and virus-like particles are similar to native virus particles. They are very similar to that, but they do not contain the viral genome. That is very important to note. Again, they cannot replicate, but can mimic the viral antigenicity without being pathogenic. That is the most important thing to be noted. They cannot replicate, but can mimic the viral antigenicity. And they are capable of inducing a strong humoral and cellular immune response. And then this VLP as a vaccine is a novel thing, and this is the most important innovation by the Kedla company. Now there has been a phase 3 study again clinical trial, safety and immunogenicity of a novel three-dose recombinant nanoparticle rabies G protein vaccine administered as simulated post-exposure immunization. A randomized comparator controlled multicenter phase 3 clinical study was done. Now in this phase 3 study to evaluate immunogenicity and safety of rabies G protein vaccine administered as a simulated post-exposure immunization in healthy volunteers. This is a randomized comparative controlled multicentric study. This is a total subject for 800. The randomization was 2:1. In one portion, 533 subjects were chosen to have vaccine for 037. This is a novel vaccine was used, and rest of 267 subjects, the rabies vaccine was used, which was 5 days regimen 037, 14, and 28. Now, what was the result? Regarding the efficacy, you can see the non-inferiority of the seroprotection. By this new vaccine, there is non-inferiority for seroprotection. Primary endpoint day 14, 42, you can see the seroprotection was as similar as day 14 as well as in 42 as compared to the rabies. Test and comparator are identical in seroprotection rate both on days 14 and 42. Regarding the safety, the event as local adverse event and systemic adverse event. Regarding the local adverse event, you can see the novel vaccine as compared to rabies vaccine, there is a lot of reduced events of adverse event as safety. It is very safe. There are less events as compared to the rabies. Regarding the local pain, redness, regarding the local adverse event, localized pain, redness, inflammation. The localized pain was less, redness was less, swelling was less. And regarding systemic adverse events, again, systemic, the fever was less as compared to the rabies. Ear pain was less, headache was less, urticaria was less, joint pain was less, nausea and joint pains were minimal. What was the study conclusion? This is a novel three-dose was non-inferior to reference vaccine, that is rabies, less adverse event compared to reference vaccine. Novel three-dose was found to be safe and immunogenic and was comparable to the 5 doses that WHO pre-qualified vaccine. Now, you know this vaccine, pharma innovation, this was by Economic Times, it was declared as pharma innovation of the year, got the award. Again, a award was given by the Malaysia, the Golden Globe Tiger Award, Innovative Product of the Year. We know about this particular vaccine. What are the good about it? We know why this all happened, because in earlier the vaccine which was developed was 25 doses, then they were because of non-compliant it came 14 doses, then it came to 5 doses. Now with this novel vaccine we have only 3 doses. Shorter duration, compliance is good, and you know the first was from the spinal cord material, brain material, then came the cell culture. Now we have protein summit vaccine, only antigenic G protein. So there are less adverse events and compliance is 100%. And then we have a various evidence evidence for it. Phase 3 study has the largest ever sample size for approval any rabies vaccine trial done in India. Trial is approved by DSCGI based on WHO guidelines for the approval of the new rabies vaccine. Rabies 3 dose has identical seroprotection at day 14 as well as 42. We have a data to prove that. The recombinant G protein vaccine, it is most advanced VLP technology to stabilize G protein. Only antigen doesn't require whole virus in the vaccine. Higher immunogenicity, still much safer and less adverse effect, and precise antigen dose 50 microgram G protein given compared to more than 2.5 ml, 2.5 international unit per viral count. So we have now a very good vaccine where the compliance is good, results are good, safety is there, less adverse event, immunity is good. So I think Any other, you have a information about this vaccine like to share with my colleagues? Any question and answer from my colleagues, I will love to answer.
Sir, I think there is no question from participant. Any question can drop in drop box.
Because no, it is everyday practice, and most of the doctors, general physician, everybody, everywhere you see the dog bite is very common. The dog lovers are there, street dogs are there, and people are touching, and some are very sympathetic to the injured animal. They are likely to have infected rabbit. We do not know who is a rabbit animal or not. Then we have to be very careful, especially where people are living in caves, we are living in dark, where the bats are there, and even the careful for the dogs and the monkeys and the cats. Some are keeping the pets. I think one has to be very careful. One vaccination is very good. You should go to veterinary doctor and get your pet vaccinated. And if you are handling the animal, then you should be vaccinated also. And I don't think this incubation period is for the rabies is 20 to 90 days. Then even some people have reported after 6 years. The vaccination is very important. Earliest use within 24 hours. You should not wait for any time to start with the vaccination. Post exposure prophylaxis should be started earlier. Instead of 5 doses, we are now 3 doses. I think the vaccination part, especially in the rural part, we do not have access to this. I think my talk, I think they should be given this information to all the rural areas and the even urban areas and the people who are a pet lover, whether they are keeping dog, monkeys, or the cats, they should be very careful. And vaccination of the pets, as well as they are bitten. Whenever there is even bite, small bite, higher bite, a big bite, a dirty bite, then we are globulin, rabies immunoglobulin has to be given also. This is available in big cities also. So I think we should have a more protection areas. We should be easily access to the HRIG, human rabies immunoglobulin also, and the vaccination also. Now the cost is also affordable because of the three vaccine. I think a lot of work has been done on this. India, the Kerala company is on top of it. I think more information is required to all the people who are dog lovers, who are keeping the pets. They have to be very careful maintaining their lively because this is a deadly disease. It is preventable. That is what we should know. It is preventable. We can always prevent it. But once you have rabies, it is only days to week that you are going to lose the life. So there are 20,000 deaths every year from India. So we have to be very careful. This is one, say, every 9 minutes, 1% we lose with the rabies. So we have to be very careful. This is my message to all the pet lovers and the physician. We should guide our patient to have the complete course and compliance should be there. There should not be deviation from the date which is recommended to the patient for the vaccine.
Thank you. Thank you so much, doctor, for your informative talk. We appreciate your efforts. Thank you, doctor.
Thank you very much, sir. I must thank all the participants and especially the Kerala people inviting me for this particular information sharing with my colleagues. Thank you very much, sir.
Thank you, sir. Have a nice day, sir.
Sir, can we end this meeting?
Hello.
Yes, sir.
Can we close it or we have to wait?
Yes, sir, we can close it.
Close.